Where is this pneumonia? Talk about this, guys. Pardon? In the left lower lobe pneumonia, what is silhouetted? So really, in the left lung, there's only the upper and lower lobes. So it's probably the left upper lobe. It doesn't occupy the apex of the lung. So this is actually in the lingula. The lingula is like the equivalent of the middle lobe of the left side. So there's the apical portion of the left lung and the lingula. And actually, this is inferior lingula, because the inferior lingular pneumonia silhouettes the heart. Oh. So this is a retrocardiac opacity, where you're not able to trace the left hemidiaphragm all the way. You should actually be able to trace them all the way through, even behind the spine, the air bronchograms, and then you're missing the portion of the left hemidiaphragm that's behind the heart. So that's the left lower lobe retrocardiac pneumonia. It's more clearly seen on the lateral there. Actually, even just from the lateral, it's not really radiology talk, but even from the lateral, I would know this is in the left lung. Why would I know that's in the left lung? Great. And how do I know that that's the left hemidiaphragm? Very good. Usually it's higher than the right. And also the heart obscures the left hemidiaphragm, and this hemidiaphragm is not obscured by the heart. So you never have a lateral without the AP. So this person was actually in the ICU on high flow. And what looks like, as you point out, like a RELP is read by the radiology resident as a normal X-ray initially on the AP, then the PA. But the radiographic severity has very little clinical correlate with the clinical severity, actually, in pneumonia. How do they get hypoxemic? These are the classic, like, West mechanisms of hypoxemia. So this individual with that CT scan, what would you guess the predominant mechanism of hypoxemia? I can tell you it's not A. Yeah, you're not wrong to say VQ mismatch. I would not disagree with that. VQ mismatch is truthfully like most causes of hypoxemia. I would say in a severe low bar pneumonia, somebody has shunt. Yeah, they have shunt physiology. What that means is this area of the lung is getting blood flow, but it's not being ventilated at all. So that's an intrapulmonary shunt. I'm not going to spend too much time on this in terms of the physiology, but just to go over why it's shunt and why it's so problematic. This is a schematic of the lung in which this side's normal, and let's just say, for example, this right lung is completely shunted and filled with pus. These are the pulmonary arteries and then the pulmonary veins to go back to systemic circulation. What's the amount of oxygen and pressure in the air? What's the atmospheric pressure in millimeters of mercury? Right, and how much of that is oxygen? Which is like 160, and the rest of it is, yeah, for the most part. So there's another gas in the trachea, which is water vapor. So then the amount of oxygen is 150, and then in steady state, the alveoli has oxygen of 100, and then carbon dioxide of 40. Venous blood, on the other hand, has oxygen of 40, and the predominant property of the lung is to oxygenate blood and remove carbon dioxide. So oxygen comes in, carbon dioxide comes out. And this fully equilibrates here. And you can see with the shunt physiology, that doesn't improve at all. So then what is this person's oxygen saturation? You had a 50% shunt, as I showed right here. Yeah, so the trick here is this is the PaO2, and the oxygen content is determined purely by the saturation. So the PaO2 maps to the saturation, but not linearly. So 100 PaO2, the partial pressure translates to a stat of 100%, but for venous blood it's 75, which determines the content. Therefore, this person has a stat of 88%. So it's weird to think about, but like if you had a 50% shunt, like one of your lungs was filled with mucus, at least in the short run, your oxygen saturation would be 88%. The reason that is because the baseline saturation of venous blood is 75. So that's like the baseline from which you're starting. Eventually, it would get lower and lower as the oxygen in the venous blood dropped. But like if you acutely did this to somebody, and this is why this problem doesn't get better with oxygen. So this is why severe lobar dense pneumonia can be refractory to oxygen therapy. Shunt classically doesn't improve with oxygen because let's say you put somebody on 100% oxygen, the PO2 goes way up. And the PO2 in the alveoli goes up, and this goes up, but the SAT's still 100%. So fundamentally, this problem can't get better because at rest, blood is oxygenated maximally. So there's no like resiliency or reserve to superoxygenate the other blood to make up for the lack of oxygenation of the shunted blood. Anyway, the Affordable Care Act was passed in 2010, which is like multifaceted piece of legislation, one of which was this whole most legislative solutions to healthcare problems really taking a turn away from pulmonary physiology, talking about healthcare legislation. But anyway, most proposed legislative solutions to healthcare problems are focused on patient health insurance, which is valid. Obviously, we want people to be insured. However, like the problem with our healthcare system is that we spend a whole bunch of money and our outcomes are terrible. And there's actually low-hanging fruit on both of those ends. And the Affordable Care Act was the first major piece of legislation that tried to address some of those issues, the fact that the quality of our care is poor and that it's expensive. And one of these is this whole readmission thing. So for these three most common diagnoses that lead someone to be an inpatient on a medicine service, hospitals after this run-in phase got dinged for a certain readmission rate. Which, and this shows that over time the readmission rate has improved, and highlighting that pneumonia, the number I think to keep in mind is like with CAP, like 17% of your patients are readmitted, so like astute discharge planning is like, paramount to avoiding readmissions. I don't really care about readmissions, but for those of you that do. Bronchiectasis is a long-term sequela of pneumonia. Bronchiectasis is airways disease in which the airways are no longer functional in terms of their ability to clear mucus. This becomes a nidus for future pneumonia, and it's actually like in and of itself a low-grade inflammatory illness. So people with bronchiectasis have like symptoms and dyspnea and weight loss and feel poorly, and that there's many causes, but the most common is having an old pneumonia that scars over in this way. The mucociliary elevator of the lung is disrupted. Cavitary pneumonia is possible as well. It's most common in people who are immunocompromised, but it can just be unfortunate luck with a really bad bug. Interestingly, the lung, unlike other organs, particularly the liver center has this tremendous ability to heal. We've known that since the 50s, where we had poor TB treatments. People get these big cavitary lesions due to TB, and there would be a remarkable range in how people would heal, from like completely normal to completely like scarred and pulmonary cripples, for lack of a better term. But it's remarkable actually to see somebody with the most severe cavitary abscessed bronchiectatic lung, and a few weeks later the lung is normal. So there is a regenerative capacity. This is mortality related to community-acquired pneumonia. This is a preeminent journal in our field. Over a 15-year period, how they ended up with this baseline mortality is a little bit more complicated, but it's just the point being that if you're admitted for pneumonia, your rate of dying is higher than all comers, and even if you're less than 25 years old. So this is just for 25-year-olds in a 10-year period, the risk of mortality versus the baseline on inpatients are worse than outpatients. Of course, that's bidirectional. Like 25-year-olds that get pneumonia probably have some predisposing condition, but it works the other way too. Like, I mean, if you get pneumonia, there's like a persistent systemic inflammation, a procoagulant state. You may have suffered organ dysfunction during that hospitalization, like APN and AKI, that stays with you. If you have bronchiectasis, you are at risk for future pneumonia. So a young person with CAP is a pretty serious illness, and they also, it is the leading cause of death in our age group. That's like non-trauma or suicide. Into your age group, which increasingly I can't do, but maybe I can still get away with it a little. So where is this pneumonia? Right or left? the medial segment of the right middle lobe silhouettes the right heart, the right atrium, which is seen well here. So this is the right lower lobe, the medial segment of the right lower lobe, which that's the radiographic appearance. It's the only sort of segment, if fully consolidated, wouldn't silhouette any other structure. But that's just like pulmonary fellow trivia. Medial segment of the right segment of the right lower lobe.
Lower, right?
Right.
Okay,
lower,
I thought I heard middle,
yeah,
and I was like, well, the hardboard is actually
correct,
pretty.
correct. It's a trick question almost, because the right lower lobe generally silhouettes the hemidiaphragm, but it doesn't here. The severity of illness of CAP is, there's two major severity of illness scores that are in use. One is called the Curve 65, the other is the Port score. So this is the Curve 65. I'm not necessarily suggesting you use this, but they are kind of designed to prevent an issue of over-admission related to pneumonia. So pneumonias, we very rarely don't admit someone that needs to be, but we do manage people as inpatients that can be managed as outpatients. And these features are things to think about in terms of how you would triage somebody. So these are clinical presenting features of the Curve 65. It's pretty straightforward, 65 referring to age. The Port score is a little bit more complicated. It's a series of features, which I'll show you in a second, that give you a score and then a class, and then it maps to a certain mortality. And this is, it's very complicated. It's designed, it's from a while ago. It's designed to be automated within health systems as a way to help with triage decisions, but it hasn't had very wide uptake. And there are these scenarios where clearly more ill people will end up with a lower score than clearly less ill people. But they're out there. The Port score and the Curve 65. Again, I don't suggest you use them necessarily, but just be aware of ER admissions that can be managed as outpatients. All right. So these are the etiologic agents of pneumonia, right? Generally bacteria, viruses, and fungi. What is the dichotomy of bacteria that you like? What's a good branch point for bacteria? When you're thinking about somebody with CAP. Affected by the antibiotics. Yeah. So what are the major classes of bacteria within pneumonia? Or what am I thinking? Good. And how would you call the strep and all those other bugs that you're thinking? Category. And even higher than that, or a more a broad label. Yeah, within community-acquired. So bacterial community-acquired are opportunistic, so are viruses, and fungi are endemic, or they're molds. Molds affect, in terms of fungus, molds infect the lung and yeast, cause bloodstream and elsewhere infections. That doesn't work perfectly, generally speaking. Community-acquired bacteria, as you point out, are typical or atypical, and then opportunistic ones are a variety of others. Mycobacteria doesn't always have to be opportunistic. Opportunistic meaning preferentially affecting an immunocompromised individual. But the most common opportunistic bacteria is nocardia. The community-acquired viruses you're very familiar with. Obviously, it's like flu, rhinovirus, COVID. And then the opportunistic ones are the human herpes viruses, which are HSV, VZV, and CMV, not EBV. And endemic mold are sort of regional, which I'll show you, and then environmental ones, you really have to be quite immunosuppressed. Aspergillus and Mucor. This is a good starting point. What is the difference between typical and atypical bacteria? Thoughts? You're not wrong. You're not wrong. What is the origin of that term?
Cell wall.
Cell wall.
So differences in your ability.
Pardon?
The differences in the cell wall.
You're probably right.
Chest X-ray finding. That's a classic representational chest.
So this is what it's sort of come to mean, but the origin of the word is just what could be cultured on standard media versus what couldn't be. That's what typical bacteria means. So typical ones can be cultured on standard media. You find them. Atypical ones can't be. So there are difficult diagnoses to make. It requires specialized testing, either specialized cultured media, specialized labs, PCR-based testing, or acute and convalescent titers. The reason that no one in this room has cared for a patient with mycoplasma is because you don't test for it. You very well may have, you just didn't know. Mycoplasma is, walking pneumonia. A lot of people say they have walking pneumonia. I'm not sure why. But yeah, so these are the organisms that can be. There are differences in the clinical presentation. You're right. So like, what are some differences in the clinical presentation that you're aware of? Has what sort of extrapulmonary features? Yeah. So while those things are maybe true at the population level, in one person, they are not accurate enough. Legionella, mycoplasma, psittacosis can cause dense lobar consolidation, and strep pneumo can cause diffuse bilateral consolidation. So the clinical presenting features in one person are not reliable enough for you to. All this term means is what. So you shouldn't think like, I'm hanging my hat on Legionella because the sodium is one. So what is the most common cause of pneumonia? Sorry? Yes, and that was our understanding for a very long time. You're not wrong, that's the most common bacterial cause. This is a relatively recent sort of update of our understanding of the etiologic agent of pneumonia. This is from a prospective study of 2,500 people in Nashville and somewhere else, in which they were admitted for pneumonia, and they underwent extensive diagnostic testing for the etiologic agent with cultures and urine antigens and acute and convalescent titers and PCRs and everything, and finds that like of the more common causes of pneumonia, all of these are, this is pre-COVID obviously, all of these are viruses. And then strep pneumo is the most common cause of bacterial pneumonia, but all of these are viruses. So people who present with CAP, who the physician believes have CAP, lobar consolidation in a sick person, actually only has rhinovirus identifiable. So viruses are much more important than we previously thought, and they probably coexist. So without getting into the nitty-gritty, viral infection of the lung predisposes to bacterial invasion and vice versa. And as an example of that, this is a study in sub-Saharan Africa of giving children pneumococcal vaccination versus placebo. And there's a reduced total number of pneumonias, as you might expect, but there's also fewer viral pneumonias, oddly. So you vaccinate someone against pneumococcus and they have fewer viral pneumonias because they're co-pathogenic. There's a special evolutionary relationship between rhinovirus and strep pneumo, such that if you identify one rhinovirus, you should have a high suspicion for strep pneumo. It co-evolved. So what bugs do you think about in CF? Absolutely. For bacteria. And Staph. Yeah. COPD. Yeah, those are common organisms. Anyone with structural lung disease can do pneumonia, but patients with COPD are not at special predilection for having staph. Hemodialysis. Hemodialysis as contact with healthcare system. Yeah. Actually, so the point making is that frequent contact with healthcare system raises the possibility of staph very significantly. Other gram-negative runs a little bit. And structural lung disease is pseudomonas. Alcoholism. Yep. Birds. Yeah, it's generally like a self-limited viral illness, but can cause pneumonia. Rabbits. Yeah, acute fever. One of those things is like persistent fever. of unknown origin for a while, but there's a mnemonic version of Q fever, farm animals. That's Q fever. Hypoxia, and sorry, Brentiella tularensis is tularemia, which is also a glandular or pneumonic. Rodent droppings. Sorry?
They have antivirus?
Yep. Which, like the rest of these, is usually self-limited pneumonia.
Absolutely the organ.
On the same deal. Very high rate of strep pneumonia. So is HCAP more similar to CAP or HAP? Yep, it's CAP with risk factors for MRSA and pseudomonas. In fact, the IDSA and ATS have eliminated that label because it's just like this blunt binary classifier. And instead, you're supposed to base somebody's MRSA or pseudomonal risk based on their healthcare contact and the prevalence of the organism. And as you know, we went over that a little bit. Our local prevalence of both of these organisms is very high. So recent antibiotics in contact with healthcare system sort of, you can in a non-binary way, like more probabilistically, think about somebody's MRSA and pseudomonas. This is kind of a rough map that shows where these fungi are endemic. This is not really fully true, I think. So blasto is in like the Great Lakes area, and then histo is more in the Ohio, Mississippi River area, and we're actually probably pretty close to histo. Coccidio is in San Joaquin Valley fever or whatever, in the Southwest. And this Cryptococcus gattii is really very localized to Vancouver. You guys heard of Cryptococcus gattii? I won't waste time. Anyway, okay, so the difference between HAP and VAP, obviously HAP is a nosocomial pneumonia person admitted for somebody else. They've been here for at least 48 hours, so they're admitted for a different pyelonephritis or whatever, and they develop a pulmonary infiltrate. That happens early. They generally have community organisms. Later, it's a hospital organism. And VAP is similarly intubated for something else and then develops a new pneumonia. So one VAP a day if somebody intubated. Do you need a CT scan in the work of a pneumonia? If the X-ray is equivocal or somebody's immunocompromised, a specific radiographic pattern can help with a differential of the etiologic agent, like is it PCP, is it nocardia, that sort of thing. But generally speaking, no. There's no evidence for a CT scan-based approach leading to improved outcomes. You need a sputum culture. What are some pros of it?
You can get sensitivity.
Pardon? Yes. Round is really long as the
False negatives. I don't know that really.
And anything you find, you're already treating for. There's very little therapeutic implication of the sputum, except if somebody has risk factors for MRSA and pseudomonas. So outpatients, no sputum culture. Mild disease, no sputum culture, because your ceftriaxone or azithrofluoroquinolone is covering the strep pneumo that you're going to find. So only if you have risk factors for MRSA or pseudomonas, those organisms are non-fastidious. So if you get a good quality purulent sample, you should identify it. Double cultures. Yeah, that's exactly right. I mean, I think you should, it's for something else, that they're hypotensive or a suspicion of bacteremia. But blood cultures are completely useless if somebody's gotten antibiotics, much more so than sputum culture. Sputum cultures are less useful after antibiotics, but blood cultures are. So the yield is very, very low, and if somebody's gotten antibiotics, for the purposes of pneumonia alone, they're not very useful. The yield is very low. Half of them are false positives, and it's quite a bit of blood, actually. So very severely ill. Urine antigens. Yeah, you're treating for Legionella and Strep pneumo.
Oh, really?
That's like your antibiotics are designed for those two organisms, you know, you know, they're very expensive. The benefits of them is that they stay positive, like, after antibiotic administration, which is nice, and they stay positive for a while. There is this, like, in vitro idea that fluoroquinolones work better for Legionella. That's never been proven specifically, like, clinically. But if you do identify Legionella, you know, you do use the high-dose fluoroquinolone. So there's a theoretical, like, sort of treatment implication. I send it as a pulmonologist if, like, the infiltrate is equivocal. Is it pneumonia or is it a variety of other things, inflammatory, heart failure, that sort of thing? Then it pushes the needle towards pneumonia pretty heavily if one of those things is positive.
And then you'll just empirically treat them.
Correct.
Results, right?
Correct. Which is a very important point, is that pneumonia is always a working diagnosis. Because the differential of a pulmonary infiltrate is so broad, including cancer, pneumonia, heart failure, autoimmune conditions, that it has to have the right clinical presenting features, which are shared among many illnesses in treatment. So it's a working diagnosis. It's very hard to diagnose pneumonia, as you go. Should you send a respiratory viral panel? Nothing about COVID. Everyone should be tested for COVID, obviously, and everyone is. Yeah, why no? Exactly. That's exactly right. That's exactly right. So first of all, these numbers are made up. So this is the company that provides the respiratory viral panel that we use in this hospital. And no idea where this came from because there's no gold standard. So they basically sensitivity off of their own arbitrary, like, PCR cutoff threshold. Then from there, as you point out, if you identify coronavirus, well, not COVID, that's a bad example. If you identify human metapneumovirus, how does that change your therapy? If you found somebody with CAP that had human metapneumovirus, if you stop antibiotics, there's co-infection that's very, very common. So, it's unclear how many of us in the community just have human metapneumovirus that's asymptomatic. So it could be true and unrelated. There could be co-infection. It's expensive, and nothing you find is treatable. I don't send these. The problem is, at Georgetown, the good flu PCR is built into the respiratory viral PCR, whereas there's the rapid flu test used in the ER, which is the antigen test, which is largely inaccurate. When you want to do a flu PCR, you have to get the respiratory viral PCR. So anyway, you should definitely get a flu swab. This is survival with of severe flu with early initiation of Tamiflu. Progressively earlier initiation leads to better survival. The benefit of Tamiflu may be overstated. It's actually a little bit debatable, but you know, for right now, the company line is that Tamiflu improves outcomes. So you obviously test for flu. What about procalcitonin?
Yeah, I mean, I feel like we do this, and
Have they fixed the turnaround time issue for procalcitonin or no?
Variable. Sometimes I can get back in a day. Sometimes
It's VHC, it's like
VHC is like
fast,
30
because they
minutes.
run it. Yeah.
Yeah.
Yeah. So, well, that largely informs the decision at Georgetown that you shouldn't send it. There's no
point.
There's no point.
well, like back home, we get it in like a couple hours, like 2 hours.
Where?
In Louisville.
Oh,
Because they turn over fast, so we would get it all the time there.
yeah. Issue with procalcitonin, irrespective of the lab turnaround time, is that it's just not accurate enough. Like, it misses like 10% of people who have bacterial pneumonia. It misclassifies people with bacterial pneumonia, so it's just not quite accurate enough. Having said that, there is a role perhaps in antibiotic duration. So even though it's an odd sort of paradox, which is that although it's not great to diagnose pneumonia, if it is positive, you can follow it for when to stop your antibiotics. There's different protocols. There's not a universally agreed upon one. And you'll find that, like, if you give pneumonia antibiotics for like a week or something, or just stop when it's below a certain value, you'll use less antibiotics, and then the outcomes will be the same. This is just to show you, emerging in our field very recently, this is patients who present with septic shock, and that got standard of care therapy for whatever the presumed infection was versus procalcitonin guided, which generally means that they get fewer antibiotic days. Outcomes were better because antibiotics are toxic, particularly in ill people. To create multi-drug resistant organisms, we call C. diff, all kinds of stuff. So this is not pneumonia specifically, but procalcitonin probably does have a role in antibiotic duration, but not for
indirectly
diagnosis.
because it reduces the
Duration,
of
correct,
antibiotics.
significantly.
So then
From
you
like
sending it or
7
not?
weeks long to like 3 days. What?
So then, if you got it back the same day, would you send it or not?
Yeah,
You would?
yeah.
Yeah, okay.
Mm-hmm. But
Only for this
reason,
reason, right? Like,
yeah.
not, I mean, diagnostically, it
Correct.
has no utility, but yeah.
Correct. Air swab.
Yeah,
Yeah.
I like this.
And a moving target with conflicting data. However, I'll just show you, it's fast, it stays positive. So if you have risk factors for MRSA, meaning that you're treating the person for MRSA, you should.
Yeah, ours is a culture that's not PCR.
Right.
That's what,
Correct. So this is a meta-analysis that includes places that do both culture and PCR for MRSA and finds there's a very high negative predictive value to the, a negative test usually indicates that they don't have a lower respiratory tract infection with MRSA. These numbers are inflated because, again, there's no gold standard. But having said that, again, it's a moving target, and the most recent iteration of the IDSA student pneumonia guidelines suggests doing it for vancomycin. And I'm not going to talk about this much. Okay, so outpatient antibiotics, amoxicillin. What are some downsides of amoxicillin? If you are in urgent care or see an outpatient or from the ER, someone you can send home, this is the IDSA recommended first-line therapy is amoxicillin for CAP. 3 times a day. And then a percentage of people, like 10% of people get that amoxicillin mobiliform rash, which is not like a true allergy, but it's kind of annoying. The alternate is doxy, which is nice because it's BID. You'll notice that there's no atypical coverage, but then patients still end up doing fine in clinical trials, probably because healthy people would have done fine anyway. The macrolide is no longer recommended as like monotherapy. Why? That's one. Yep. So strep pneumo resistance to macrolides is rising and is like 30–40% in this region. So, fortunately can't rely upon it. The comorbidities are like anything, like heart, lung, renal, liver, whatever. Most likely they have had antibiotics before, or have had contact with the healthcare system. That's the recommended therapy. You guys are very well versed. This is based on clinical trial data showing that fluoroquinolones and ceftriaxone and azithro are non-inferior to each other. For the treatment of pneumonia, fluoroquinolones have a worse side effect profile, so we use ceftriaxone and azithro. And this is not speaking about risk factors for MRSA and Pseudomonas. Of course, you test for those and treat for it. So what percentage of strep pneumo is ceftriaxone resistant? That website is, shows that it has a whole bunch of different bugs and different antibiotics, and you can see sort of the low levels of resistance. Yeah, it's like in the 5 to 10 range. That's why you give vanc and community-acquired meningitis. So community-acquired meningitis is treated with vanc ceftriaxone because this 10% of strep pneumo that's ceftriaxone resistant is very important in meningitis. It's less.
Does the larger dose of ceftriaxone not address that?
It can.
Okay.
It can. Yeah, that color scale means that. And this is, so this is from right here. This just shows macrolide resistance is getting higher. I'm going to skip this. Should use steroids. You guys heard about using steroids for pneumonia? I mean, that's. Sorry? Yeah. There's like certain hospital systems that advocate for it. This is a JAMA trial in which inpatients with CAP who had an elevated CRP were given steroids, and they suggested that there was improved outcomes, but it's all like intermediate stuff, like the x-ray got better quicker and they effervesced quicker, but there's no like long-term outcome that's better. I think Kaiser does this. It's generally not our practice. Cover anaerobes and aspiration. 2 more questions. Anaerobes and aspiration. So this is based on an old study that used weird culture techniques. It's like literally from the 70s where they're doing like transtracheal needles and pleural biopsies and found all these anaerobes in aspiration pneumonia. Problem is, what is aspiration pneumonia and how does it differ from regular pneumonia? all pneumonia, I guess, is fundamentally aspiration, or it's, septic emboline hematogenous, but that's kind of a different clinical picture. Anaerobes, even if they're present, it's unclear what their pathogenic role is. And the anaerobic therapies have a lot of side effects. The data suggests not doing that. So if you think someone aspirated, you just give Flagyl also. Does somebody need to be off oxygen before you send them? I see what you're saying. This kind of dovetails into a larger conversation that we won't have, but the whole paradigm of oxygen prescription comes from these studies from the 70s and 80s. I'm showing one from the 80s for COPD. So in COPD, you guys probably learned that, if your stat is under 88% or something, you should get oxygen. That's before modern bronchodilators, before every modern treatment for COPD. And actually, a replication of this study in COPD patients alone, and with like modern bronchodilators and lung cancer screening and all that stuff, smoking cessation, does not replicate this finding. So the entire oxygen thing is expediency. 88% thing is based on this study from the 80s, with that we then take that to mean that your young patient with pneumonia needs to be over 88% when they walk before they go home.
What's the y-axis here?
I don't know. Percent surviving. Yeah. So, again, 1 million years ago, they showed that oxygen helps people survive if they use it in COPD, but that was, when they were using Primatene Mist. So someone does not need to be off oxygen, meaning that if they are symptomatically not worse for the wear when they're not on oxygen and they're desaturating mildly, and you expect them to, you don't need to send them out. You don't need to remain an inpatient until they're off oxygen. The pneumonic effusion, so this is the lung, this is the pleural space, and this is the liver, and that's the pneumonic effusion. Pneumonic effusions always have to be drained. So pneumonic effusion is a pleural effusion next to a pneumonia. The reason it always has to be drained is that antibiotics don't reach that space very well, and then very quickly, what is that simple layering fusion can end up like this. So this is the liver, diaphragm, and lung, and this is like a septated, fibrinous pleural space that now will potentially require surgery. So you take a problem that you can deal by draining it to a surgical problem with a high morbidity. So in this process of a simple pneumonic effusion becoming an empyema happens very, very, very quickly. Do you need to get a follow-up x-ray? Last slide. You guys heard of that concept? That with pneumonia, you get a follow-up x-ray at 6 weeks to make normal? No, you don't need to do that. But that was in a previous iteration of guidelines. But if somebody has lung cancer screening, if they're eligible, meaning they've smoked. This is the last slide. A 48-year-old woman is admitted with 1 week history of nasal congestion, rhinorrhea, dry coughs, fevers, chills, and myalgia. She was beginning to feel better until 48 hours ago, where she developed recurrence of fevers and chills, cough productive of sputum, right-sided chest pain, no hospitalization. She has type 2 diabetes. On oral hypoglycemic, she's febrile, a little bit tachypnic, tachycardic. Laboratory study shows a white count of 20, BUN 28, serum creatinine of 1.3, and there's a right middle lobe airspace disease with cavitation and a small pleural effusion. So what antibiotics? Yeah, the answer is C. So I think on history, they're trying to describe something that's like a flu-like illness that had improvement followed by recurrence of issues. So this is clinically they're trying to get at, this is a post-flu staph pneumonia, which the area of cavitation suggests Staph aureus. So you would cover for a regular cap and then treat for the possibility of community-acquired MRSA or MSSA. So this is post-flu staph pneumonia.